Hello all, welcome back. Today we are discussing thyroid and parathyroid. These are the topic breakdown given in the syllabus. Neck mass evaluation, thyroid nodule approach, surgery for hypothyroidism, thyroid cancer, complications of thyroidectomy, and primary, secondary, and tertiary hyperparathyroidism. So let's get started. Here is a simple anatomy for the thyroid. Thyroid gland is situated from C5 to T1 vertebrae. Okay, and also it extends from the oblique line of thyroid cartilage to around 5th or 6th tracheal ring. It has two lobes, a right lobe and a left lobe, which is connected by the isthmus. There can be an additional lobe, okay, which is a remnant from the developmental stage, that is called a pyramidal lobe. And it actually develops from the foramen cecum, okay, along with the ultimobrachial body. So this is the ultimobrachial body, and the foramen cecum is we have our tongue, we have the anterior 2/3 and the posterior 1/3. In the midline where it fuses, we have something called foramen cecum. Okay, so foramen cecum along with the ultimobrachial body that develops into thyroid. So I've just added a picture of pharyngeal arches and pouches and cleft. So pharyngeal arch means it is mesoderm. Okay, so these are embryonal structures. It is important that we know the derivatives of them and what are the problems happening there. So pharyngeal arches are mesoderm. We have 1, 2, 3, 4. 5 is actually not developing, and we have a 6th arch. And then we have cleft, which is the outerward invagination on the outside, and they are ectoderm. Okay, so it is outside, so it is ectoderm. So the first pharyngeal cleft, as you see, is forming into the external auditory meatus. Okay, then we have pouches, okay, which is on the inside. So they are endodermal thing. So the first pouch is forming the eustachian tube and the tympanic cavity. So the first thing, cleft forming external auditory meatus, pouch forming eustachian tube and tympanic cavity. Second pouch, palatine tonsil. Third pouch, inferior parathyroid. As you see, inferior parathyroid is from the third pouch, superior parathyroid is from the fourth pouch. That may seem a bit complex, right? But as they migrate, third one is going even down. That is why thymus is also forming with the third pouch, because thymus is then say in the mediastinum, right? That means that is migrating even more than the fourth. That is why superior parathyroid is forming from the fourth to sixth pouch. That combines and form the superior parathyroid and ultimate brachial body, which is also forming a part of thyroid. Okay, and the second, third, and fourth cleft, they just join to form the cervical sinus. We'll discuss when we discuss the brachial sinus or cervical sinus, which can remain and act as a remnant, and they may either form a sinus or a fistula. Okay, so this is it. This is the thyroid gland development. So this is a picture showing the uh, tonsil, lingual tonsil, and here is the foramen cecum. Hope you can see that this is the junction between the anterior 2/3 and posterior 1/3. This is the foramen cecum, which is which along with ultimobrachial body forms the thyroid. So actually, if that is there is a foramen cecum, okay, and there is an ultimobrachial body, okay, ultimobrachial body, and then they are forming this thyroglossal cyst, thyroglossal tract, and they are first forming that thyroglossal tract, then they are dividing on the lower end, it becomes bifid, and then it forms two glands, and sometimes the superior part remains, that is the pyramidal lobe. So this is the right and left lobe along with the isthmus and the pyramidal lobe. So this is how the thyroid gland develops. Sometimes what happens is that it fails to migrate. That is when you have a lingual thyroid. That is in the tongue itself, at the site of foramen cecum, you can have a lingual thyroid. So that is why this development becomes important, so that you understand what happens when any step in the development goes wrong. So if it fails to migrate, it can form lingual thyroid or any ectopic thyroid along the thyroglossal tract. Okay. Also, the remnant of this thyroglossal tract, can become the thyroglossal cyst, or it can fistulate to form thyroglossal fistula. We'll talk about it later. Coming to a blood supply, so we have the arch of aorta. Okay, on the right it's giving a brachiocephalic trunk, on the left it's giving subclavian, left subclavian and left common carotid. The brachiocephalic trunk on the right is dividing into right subclavian and right common carotid. The subclavian has three branches. You can remember it like width. So the first part of subclavian has three branches, which is vertebral, internal thoracic, and thyrocervical trunk. So this is your thyrocervical trunk. This thyrocervical trunk is giving three branches. You can remember it like SIT, suprascapular, inferior thyroid, and transverse cervical. So thyrocervical trunk is giving out this inferior thyroid artery. Okay, then you have your common carotid artery, which is dividing into the external carotid and internal carotid artery. This external carotid artery is giving out a branch which is called superior thyroid artery. These are the main two arteries of the thyroid. Sometimes you also have a thyroid EMA artery, which is from the common carotid itself. Thyroid EMA artery. Why is this important? Because during surgery these all may bleed, you have to ligate, so that is why it is important. First artery to be ligated during surgery is your superior thyroid artery, and superior thyroid is supplying the thyroid. Why inferior thyroid is important? Inferior thyroid is supplying both the superior and inferior parathyroid. So usually it's paired along with the parathyroid gland as much as possible during the surgery, so that the parathyroid is not devascularized and it can be salvaged. Okay. Now the nerve. So the one nerve which is in close relation with thyroid and it is very important during thyroid surgery is recurrent laryngeal nerve. So what is like recurrent laryngeal nerve? It is a branch of 10th nerve or vagus nerve. Also another nerve in close relation is the external branch of superior laryngeal nerve. So superior laryngeal nerve, which is again a branch of 10th nerve, has two branches, internal laryngeal nerve, external laryngeal nerve. This external laryngeal nerve is important because it is supplying the cricothyroid muscle, which is giving high pitch to the voice. So if it is damaged during the surgery, the pitch of the voice can be affected. So that is the cricothyroid muscle, which is one of the internal intrinsic laryngeal muscle. Okay, cricothyroid, the only muscle that is supplied, not supplied by the recurrent laryngeal nerve. All other intrinsic laryngeal muscle are supplied by the recurrent laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve, which is in close relation with the superior part of the thyroid gland, thyroid lobe. So the left and right recurrent laryngeal nerve lies in close proximity to thyroid gland. So care must be taken not to damage them during surgery. Damage to this can cause hoarseness of voice. So what is the root of that or path of that nerve? So on the right side, this recurrent laryngeal nerve, they coil or whirl around the subclavian artery, while on the left they whirl around the arch of aorta. You can see here, arch of aorta. Okay, and they lie close to the gland. They branch from respective vagus within the chest and hook around right subclavian on the right side and arch of aorta on the left side. They travel then back up the neck, running between the trachea and esophagus in the tracheoesophageal groove. That is where you are expecting this nerve. So it is ideal that you identify the nerve and try to salvage the nerve. You have to protect the nerve. It then passes underneath the thyroid gland to innervate the larynx, all the intrinsic laryngeal muscles except the cricothyroid. The damage to this nerve can cause hoarseness of voice. Okay, so you have to protect this nerve. Now we'll come to neck swellings. So to understand neck swellings, you have to understand the location of for different DDs. You have different locations. So the landmark here is sternocleidomastoid muscle. Anterior to that you call anterior triangle, posterior to that you call posterior triangle. Again, anterior triangle can be divided into submental, okay, which is bounded by the anterior belly of digastric, okay, and the hyoid and the mandible. So that is submental. Submandibular is bounded by the anterior and posterior belly of digastric with mandible. That is submandibular, where you have the submandibular glands and all. Then the omohyoid is dividing this triangle here into carotid triangle, where you have the vessel, and muscular triangle, where you're mainly having muscular structures. You can have mass or swelling anywhere here, and the DDs differ. We'll just look at that. So neck swelling, you can have midline swelling, you can have lateral swelling. Lateral swelling can be anterior triangle or posterior triangle. Midline swelling can be submental lymph nodes. You can have thyroglossal cyst. As I discussed, it is a remnant of the thyroglossal tract. It can also form a fistula. There can be thyroid swelling, which is one of the main this midline swelling that you have. Then hyoid bursa, pretracheal lymph nodes. You can have a dermoid cyst, which is a midline swelling along the fusion of the skin. That's along the fusion where it comes and fuses in the midline. Then you can have laryngeal swelling, chondroma of thyroid cartilage, or Ludwig's angina. Okay. Then you can have lateral swelling in the anterior triangle, submandibular gland swelling in the submandibular triangle. Thyroid gland lobe also can have present as a lateral swelling if it is a solitary nodule or a lymph node spread from the cancer. Then branchial cyst. So there are two terms here, cystic hygroma and branchial cyst. Branchial cyst is seen in the anterior triangle, cystic hygroma is seen in the posterior triangle. One more difference is branchial cyst is usually in the adolescent to adult age group. Cystic hygroma is usually at birth or less than 2 years. Then you can have pharyngeal pouch in the anterior triangle, parotid gland swelling, any tumor like parotid gland tumor or anything. Then laryngocele, lymphadenopathy, cold abscess, which is one of the TB lymph node swelling. I'll talk about the stages of TB lymphadenitis later. Then you can have a carotid body tumor. In posterior triangle, again, you can have lymphadenopathy, cold abscess, which is TB. The cystic hygroma, I told it's in the posterior triangle. Cervical rib, which is an extra rib, and subclavian artery aneurysm. They all can have present like a lateral swelling. Also, a lateral swelling can be a sternocleidomastoid tumor, like a congenital torticollis. Okay. You can have a ranula. I'll talk about it as a neck swelling. Okay, so there are a few things that we'll discuss. Then other swelling which can be seen anywhere like midline, lateral is sebaceous cyst. There can be lipoma, dermoid cyst, usually in the midline, schwannoma, okay, hemangioma and teratoma. So talking about branchial cyst. So this is the cyst that you're seeing here. As I mentioned, in the adolescent to adult period, 15 to 30 years, lateral aspect of neck at the anteromedial border of sternocleidomastoid at the junction of its upper and middle third. It's usually asymptomatic. If infected, it can be painful. Okay, it's usually cystic, soft, and non-transilluminant. Aspiration may reveal cholesterol content. So this is important. It reveals cholesterol content. So as I mentioned, this is the pharyngeal arches, and this is the downgrowth of the second arch. Okay, the fusion of usually from the second arch is where the branchial cyst is forming. The fusion of second arch with the skin of neck form the branchial cyst. It can also form a sinus or a fistula where there is a failure of fusion with the second arch. Okay. Intercystic hygroma, you see, it is usually in less than 2 years or at birth. So it can also cause uh, difficulty during labor. So it is actually a lymphangioma. The lymphatic system, there is a collection and or a swelling, and it is usually in the posterior triangle of neck. So they are relatively rare in the posterior triangle, but they can also be found in the mediastinal maxilla or groin because they are along the lymphatic drainage. They are often noted at birth, okay, and represent persistence of primary lymphatic buds. They extend into surrounding tissue but not associated with malignancy. Transillumination is a useful sign to diagnose this lesion. So you can differentiate between your branchial cyst and cystic hygroma. One is age group. Branchial cyst is usually in 15 to 30 years, or your adolescent to adult period. Okay, your cystic hygroma is usually at birth or less than 2 years. Okay, and cystic hygroma, the location is posterior triangle, while branchial cyst is in the anterior triangle. So the site of swelling is also different. Now, branchial cyst and cystic hygroma, they are both soft and cystic-like, but transillumination is negative in branchial cyst, but transillumination is positive in cystic hygroma. And branchial cysts have cholesterol thing. In FNAC, you can have cholesterol deposits. Okay, now dermoid cyst. This is in the midline or along the fusion of different bones or different structures. They are inclusion cysts that contain epithelium and skin adnexa like hair follicles, sebaceous gland, and sweat gland. 7% occur in the head and neck, especially around the orbit. See, along the fusion of different bone and bony region. Okay, in the midline of the neck also you can see a dermoid cyst. They resemble a thyroglossal cyst, but they does not move with swallowing or protrusion of tongue. That is how you differentiate thyroglossal cyst from other neck swelling. Okay, as well as thyroid. Thyroid also moves with swallowing. Then ranula, it's a mucocele that occur in the floor of mouth, usually from the salivary glands. If it's inside the mouth, it can present as swelling inside the mouth, usually from the sublingual gland. Okay, sublingual gland, and also it can present as a neck swelling, like you can, here if it is your mandible, if there is a swelling here, okay, in the anterior triangle, it's called a plunging ranula that you can you can like you can push it and it becomes like a mobile thing. It's called plunging ranula. It's derived from the word rana because it resembles the translucent underbelly of the frog, right? So it's a retention cyst of sublingual gland usually. Coming to TB lymphadenitis, there are different stages of TB lymph node. One is lymphadenitis, where there is inflammation of lymph node, and the nodes are discrete and they're non-tender. They're usually firm or hard and mobile. Then comes matting. Second stage, where the 2-3 lymph nodes, multiple lymph nodes move together, and they are firm and again non-tender. It is usually due to periodontitis. Now is what you call a cold abscess. Okay, so we told in the anterior triangle or posterior triangle we can find cold abscess. It is nothing but a TB lymph node. So it is deep to the deep fascia again, but there is coalition of so many lymph nodes and central necrosis. So in cold abscess there is central necrosis. Next stage, it is a dumbbell shaped abscess. It's a collar stud abscess, wherein it ruptures through the deep fascia under the skin. It grows fluctuant and it is adherent to the skin. In the fifth stage, it opens out and there is a sinus formation. Okay. Now, cervical rib, as I mentioned, can also present as a neck swelling, like a bony hard neck swelling. It's an extra rib. What happens and what is the problem with cervical rib is it can compress the vessel like a subclavian artery. So something called Adson test can be diagnostic. That is, if you are moving the neck to the side of the lesion, there can be weakening of the pulse on that same side due to compression of vessel. That is called Adson's test. For these, you exercise. The previous mentioned like bronchial cyst, cystic hygroma, ranula, they all can be excised. Okay. TB lymph node, you do a Mento test to confirm, and you can do an FNAC, and you can see the um, giant cell and the granuloma in TB lymph node, and you can start them on ATT. And if it's simply a lymph node, if they respond to ATT and they shrunk in size, well and good. Otherwise, you can excise. Okay, and cervical rib also you can excise. Then I just wanted to mention that nasopharyngeal carcinoma also present as a neck mass. Okay, the most common sign of nasopharyngeal carcinoma is a neck mass, even when the primary lesion is microscopic. And the first cranial nerve to be affected is abducent and indicates cranial extension. So it is associated with EBV virus also. Okay, so nasopharyngeal carcinoma can also present with the neck mass. Up to carotid body tumor. So carotid body is uh, found at the junction of bifurcation of common carotid artery into internal and external carotid artery. It's a most common paraganglioma in head and neck region, followed by glomus jugular. It grows very slowly and rarely metastasize. They secrete catecholamines, so for diagnosis you can do a serum catecholamine test or a urine vanillyl mandelic acid, which is a metabolic product of catecholamine, that is VMA. Urine VMA can be done. Okay, and the tumor is supplied by external carotid artery, and dissection to remove it off the carotid may be difficult and can cause bleeding. And it is a receptor which is sensitive to hypoxia. So usually in high altitude region, due to chronic hypoxia and chronic stimulation, there can be carotid body tumor. Okay, this carotid sinus is a different thing which is sensitive to changes in BP, but carotid body is sensitive to, it is a chemoreceptor sensitive to hypoxia. The carotid sinus wall is a baroreceptor which is sensitive to changes in BP. So 40-year-old woman is suspected of having a carotid body tumor. Which of the following is most characteristic of such a tumor? They secrete catecholamines. They are more common at sea level. No, I told you it is due to hypoxia, so at high altitude. They arise from structures that respond to changes in blood volume. No, that is baroreceptor, not a chemoreceptor. Carotid body is a chemoreceptor. Changes in blood volume is a baroreceptor. That is carotid sinus. They arise from structures that respond to changes in PO2. That is true. They are usually highly malignant. No. They secrete catecholamines is true, but which is the most common characteristic and most important characteristic is they are structures that respond to changes in pH. And in the angiography, you can see a sign which is called Lier sign, that is bifurcation of the common carotid. There is a splaying. Okay, this is a musical instrument which is called lyre, that is called Lier sign. Okay, blood supplies from the external carotid artery. It can bleed while you try to exercise. Then salivary neoplasms can also present as neck swelling. One of the most common is a pleomorphic adenoma. Half of the tumors in the parotid and submandibular glands, okay, they are pleomorphic adenoma. So the most common parotid tumor is a pleomorphic adenoma. Pleomorphic means it is different morphology. Okay, that is what pleomorphic means, or a mixture of morphology. A word on Warthin's tumor, papillary cystadenoma lymphomatosum. It's also called Warthin's tumor. Its epithelial component is interspersed with lymphoid tissue that shows germinal center. Most common tumor of the parotid gland is pleomorphic adenoma, as we discussed, with papillary cystadenoma as the second most common. Okay. Then what is Mikulicz disease? It is chronic inflammation swelling of salivary gland, which is benign and usually painless. So Mikulicz disease is benign lymphoepithelial lesion of the parotid gland, particularly when bilateral. So parotid, we discussed three names. One is pleomorphic adenoma, which is most common. Then you have papillary cystadenoma, which is second most common. You also have Warthin's tumor, which is cystadenoma lymphomatosum. Then Mikulicz disease, lymphoepithelial lesion of parotid, which is chronic inflammation and swelling of the salivary gland. There is another term called Mikulicz syndrome, where it is bilateral enlargement of parotid, other salivary, lacrimal by definable disorders like sarcoidosis, lymphoma, and sialosis. Okay. So now another neck swelling is congenital torticollis. That is due to some birth trauma. There can be hematoma in the sternocleidomastoid muscle. Then they fibrose and there is contracture of the muscle and it presents as a neck swelling. So the head is tilted towards the affected muscle and chin is pointed away from the contracted muscle. Then another term is quinsy, which is a peritonsillar abscess, usually by group A streptococcus. It can also be caused by influenza, or pseudomonas, or staph. And there can be tonsillitis. Uvula can be shifted to other side, and there is a peritonsillar abscess as well. So you do an incision and drainage. Okay, the clinical features are severe sore throat, ipsilateral referred otalgia or ear pain, or dinophagia, that is pain during swallowing, drooling of saliva, that is they can't swallow the saliva, that much pain would be there, and there is muffled and thick hot potato voice due to that edema and everything. Halitosis is foul breath due to sepsis. Trismus is due to the spasm of pterygoid muscle. And there can be fever, high-grade chill, rigor, general malaise, body pain, headache, nausea. Torticollis is when the neck is turned towards the side of the abscess. Okay, torticollis can be due to sternocleidomastoid muscle tumor or the fibrosis and contracture of the muscle due to congenital or any birth trauma, or it can also be due to something like a quinsy or a peritonsillar abscess. Okay, and you do an IND for that. Another term is Ludwig's angina, which is spreading cellulitis, mainly bilateral, involving the submandibular, submental, and sublingual spaces. Okay, here below the mandible, you have spreading cellulitis. Clinically, there is pain, drilling dysphonia, brownie neck edema, and bilateral submandibular swelling. And tongue can be elevated due to this swelling. Okay, usually it's surgical management and broad spectrum antibiotics and airway management. Again, it is caused by streptococcus or staphylococcus. Then thyroglossal cyst, which is the remnant of that thyroglossal tract. It can be anywhere along that thing. the swelling is called cyst. It can either fistulate out and can form a thyroglossal fistula also. It moves with protrusion of tongue and swallowing. It can become a fistula. Okay, and the operation for that is called a cyst trunk operation. And it is what is cyst trunk operation is, we are removing the cyst along with the tract and part of the hyoid bone also, because it is usually infrahyoid. 85% is infrahyoid. Only a few cases are suprahyoid. So you have to remove part of hyoid bone also alongside that. Now coming to thyroid and thyroid gland, the thyroid swelling, thyroid cancer and all. So first let us look at the thyroid hormone synthesis. So thyroid hormone synthesis, iodide is one of the important mineral which is needed for thyroid synthesis. Iodine deficiency had been a problem in the past, which is it is prevalent now also, but the incidence has reduced. It is due to iodine deficiency, and it causes diffuse swelling of the thyroid gland, which is called goiter. Okay, so the iodide is firstly taken up, and it is there is a step called organification. Then the iodide is incorporated into the uh, thyro, uh, thyroglobulin by the enzyme thyroperoxidase. So that is one of the important enzyme in thyroid synthesis, thyroid hormone synthesis, and that step is called iodination, and that forms monoiodotyrosine, MIT, and diiodotyrosine. Okay, and there is another reaction or process which is called coupling, which is again by the thyroperoxidase enzyme, which combines this monoiodotyrosine with diiodotyrosine, which is forming T3, that is triiodothyronine, and diiodothyronine will be uh, combined, tyrosine. Okay, it will be combined, two molecules of that will be combined to form the tetraiodothyronine or thyroxine. Okay, so this MIT is monoiodotyrosine. Okay, DIT is diiodotyrosine, T3 is triiodothyronine, and T4 is tetraiodothyronine or thyroxine. That T4 is abundantly produced because that is like a storage form. But 85% of T4 is converted to T3 or reverse T3 in the periphery by the deiodinase enzyme. So there is another enzyme which is deiodinase. Again, MIT and DIT can be converted into iodide molecule by iodotyrosine deiodinase. Okay, in the periphery, deiodinase can convert T4 to T3 or reverse T3. Reverse T3 is actually a metabolically inactive product, but it's produced in times of stress due to decreased metabolic activity. There are other extrathyroidal sources of thyroxine, like a struma ovary. It is ectopic thyroid tissue in the ovary. Okay, these are colloid structures inside the ovary, which is called struma ovary. Or an ovarian teratoma, which can have different structures. Teratoma can have hair, glands, and other structures. So ovarian teratoma can also produce thyroxine. Or a metastatic follicular carcinoma. We'll come to differences between hyperthyroid, hypothyroid, how do you manage them and all. So hyperthyroid usual features are heat intolerance. There can be palmar erythema. There can be tremor. There can be weight loss. That is unintentional weight loss. Onycholysis or plumber's nail. That is ragged nail bed edges. This is onycholysis in thyrotoxicosis, where there is distal separation of nail plate from the nail bed, which is called plumber's nail. Then there can be increased appetite, tachycardia uh, with atrial fibrillation. Then in Graves' disease, which is autoimmune hyperthyroidism, with there can be eye signs and pretibial myxedema with thyroid acropathy. Okay. So these are the eye signs in Graves' disease, usually in the orders of changes. Usually, initially, there is no eye changes. First signs to be seen are lid lag and lid retraction. Then there can be periorbital puffiness and conjunctival injection and chemosis. Then proptosis and exophthalmos. Then diplopia, corneal aberration since they are unable to close the eyes, and loss of sight. So this ophthalmopathy, that is thyroid associated orbitopathy, is due to increased connective tissue and extraocular muscle tissue volume due to inflammation and accumulation of glycosaminoglycans. This is why there is proptosis and all, which is stimulated by TSI, that increased osmotic pressure within the orbit that leads to fluid accumulation and forward displacement of the eyeball. Again, dermopathy is pretibial or localized Bigg's edema, again due to glycosaminoglycan deposition. This Graves' disease and autoimmune disorder, it is associated with HLA B8 and DR3. Also, our Hashimoto is associated with DR3 and DR4. Okay. So this is again another slide I've added to remember the eye signs in Graves' disease. J for Geoffroy sign, Darlimp sign. Jo dar gaya, samjho mar gaya, which in Hindi means those who fear, they die. Okay. So Geoffroy, Darlimp, Gaya means Gifford sign, Samcho Stellwag sign, M is Mobius, N is Enroth, R is Rosenbach, G is von Graefe sign. We'll see what each of them are. Rosenbach means tremors on closing eyelids. Stellwag means a staring look. Stellwag, staring. Okay. Darlimple is a rim of sclera is seen between the cornea and upper lid. You can see. Okay. In between the cornea and upper lid, you can see a rim of sclera. Von Graefe is lagging of the upper eyelid. Geoffroy is loss of forehead corrugation when you are looking up. Mobius is lack of convergence. Here you can see lack of convergence due to ocular myopathy. Then Gifford is difficulty in eversion of the upper lid, and Enroth is edema of the lower lid. Okay. Treatment for hyperthyroidism is propylthiouracil, which is inhibiting thyroid peroxidase, which we saw as the important enzyme which is involved in thyroid hormone synthesis. It also inhibits peripheral conversion of T4 to T3 and can be used in pregnant also. In first trimester, it is safe in pregnancy. The side effects are granulocytosis, hepatotoxicity, and vasculitis. Methimazole is preferred over propylthiouracil due to their side effects, but in pregnancy it is not given due to the risk of aplasia cutis. Beta blockers for symptomatic control, steroid in thyroid storm and severe orbitopathy. You have to remember that radioactive iodine, which can be used in the treatment of hyperthyroidism, is not used while there is ophthalmopathy. So in Graves with ophthalmopathy, you cannot use radioiodine because it worsens the condition. So this is a flowchart where of the workup of thyrotoxicosis. When there is suspected thyrotoxicosis, you do a lab, TFT. You do TSH, free T4, and total T3 and free T3. If there is low TSH, normal thyroid hormone concentration, that means there is subclinical hyperthyroidism, or it can be a non-thyroidal illness. If there is a low TSH, high thyroid hormone, which means there is hyperthyroidism in the lab value itself. So then you go up for mainly radioactive iodine uptake. That is one of the modality that you do for a thyrotoxic nodule. If there is high radioiodine uptake in a focal or a solitary nodule, that means it is a toxic multinodular goiter or a solitary adenoma, toxic solitary adenoma. If there is diffuse uptake, it means Graves' disease. If there is low iodine uptake, that means it is thyroiditis or iodine induced or drug induced or excess exogenous thyroid hormone due to iatrogenic or factitious or ectopic hyperthyroidism like in a struma ovary or functional thyroid cancer metastasis. Now, if the TSH is normal or raised and there are high thyroid hormone, that is inappropriate TSH hypersecretion. So TSH secreting pituitary adenoma or pituitary resistance to thyroid hormone. If the TSH is normal and normal thyroid hormones, it's usually euthyroidism. Now, if you're doing a thyroid ultrasound with receptor autoantibodies, if the antibodies are negative and there are no your classic findings on ultrasound, it's usually due to thyroiditis or drug-induced or ectopic hyperthyroidism. If it is nodular goiter with thyroid receptor negative, it's toxic multinodular or solitary adenoma. If it's enlarged thyroid without nodules and thyroid antibodies positive, then it is Graves' disease. Now, radioactive iodine uptake, it's a test of function if the patient is thyrotoxic. It measures the turnover of iodine by thyroid gland in vivo. If there is increased uptake, that means the gland is overactive, like in hyperthyroid cases like Graves. If there is decreased uptake, the gland is leaking thyroid hormone, like in thyroiditis, or exogenous thyroid hormone use, or excess iodine intake, like amiodarone or contrast dye, which is high iodine content. Okay. Now, Graves' disease, what are the indications of surgical management? In a woman planning pregnancy in less than 6 months, also, if you find Graves during pregnancy or hyperthyroid state during pregnancy, you can take them up for surgery. You cannot give radioiodine. Like mentioned, hyperthyroidism in pregnancy, you can give propylthiouracil in the first trimester. Methimazole is not given in the first trimester due to risk of aplasia cutis. Presence of large thyroid more than 4 cm, again surgery. Large goiters with compressive symptoms, suspected or non-malignancy, like thyroid malignancy. Concurrent primary hyperparathyroidism, which is anyway requiring parathyroidectomy, or persistent disease despite previous treatment with anti-thyroid medications or radioactive iodine. Remember, for Graves, the ideal management is surgery, usually subtotal or total thyroidectomy. The better results are with total thyroidectomy, and thereafter you can replace thyroxine. Then during the surgery, in the perioperative period, you can give potassium iodide containing compounds, mainly for Graves, like potassium iodide or Lugol solution. Potassium iodide is 50 mg iodide, 1 to 2 drops 3 times daily. Lugol solution is 5% elemental iodine and 10% potassium iodide. Okay, it should be administered 7 to 10 days before surgery. The potassium iodide containing compounds inhibit iodine organification in the thyroid, so thereby diminishing the thyroid hormone synthesis and inhibit hormone secretion. Okay, that is given only in the perioperative period. Soon after surgery, you stop all these things, and you can then replace thyroxine. Okay, you also stop the hyperthyroid anti-hyperthyroid medications after surgery. Okay, now why do we need to make the patient euthyroid before taking them up for surgery, or we have to optimize their status before taking up for them for surgery? Because one of the complications or grave complications for thyroid surgery for hyperthyroidism or Graves is thyroid storm, and it is usually happening when the patient is not optimized before surgery. So you have to make them euthyroid before surgery. So what is the treatment? The thyroid storm means it is a like a thyrotoxic crisis when the patient is having high thyroid hormones. So there is AF, there can be cardiac arrhythmias and severe hypertension. The patient can collapse. Okay, so how do you manage them? General measures like fluid electrolyte vasopressor agent should be used as indicated. A cooling blanket and acetaminophen can be used to treat the pyrexia. Propranolol or other beta blockers that additionally decrease peripheral conversion can be used, but should be used in caution with decompensated heart failure, as it may worsen the condition. Okay, so propranolol and beta blocker can decrease the peripheral conversion. Okay. Propylthiouracil is the antithyroid drug of choice and is used in high doses. So that is one thing you give. Give iodide, which acutely inhibits the release of thyroid hormones. Okay, 1 hour after the first dose of propylthiouracil is given. Sodium iodide 1 gram IV drip over 12 hour, or Lugol solution 10 drops 8 hourly, or potassium iodide 5 drops 6 hourly. Then you also give steroid. Like we mentioned, thyroid storm, you give steroid. 100 mg IV 8 hourly, or dexamethasone 2 to 4 mg IV 6 hourly for the first 24 to 48 hours. It inhibits peripheral conversion of T4 to T3. So T4 to T3 peripheral conversion is inhibited by propylthyrosol, propranolol or other beta blockers, and steroid. So you give propylthyrosol as the first line agent, then you give iodide 1 hour after the first dose of propylthyrosol. You also give hydrocortisone. Okay, now coming to hypothyroidism. What are the clinical features of hypothyroidism? There can be fatigue, cold intolerance, slowing of mental physical performance. It can be hoarseness and macroglossia. Okay, then the CV, so macroglossia 1DD is hypothyroidism. Okay, CVS there can be pericardial effusion, bradycardia, hyperthyroidism, tachycardia, hypothyroidism, bradycardia, hypertension, worsening of congestive heart failure, angina, hypercholesterolemia, hyperhomocysteemia, myxedema, heart. Respiratory, there can be decreased exercise capacity, hypoventilation secondary to weak muscles, decreased pulmonary response to hypoxia, sleep apnea, again due to microglycia. Then GI, there can be weight gain despite poor appetite. Hyperthyroidism, there is weight loss despite increased in appetite. And again, hypothyroidism can cause constipation. Neurology, there can be paresthesia, muscle cramps, delay in relaxation phase of deep tendon reflex. That is called hung reflexes. And carpal tunnel syndrome, one of the common causes, hypothyroidism. A symptomatic increase in CK, seizures also can be there. Menorrhagia, amenorrhea, impotence. So any kind of menstrual and sexual abnormalities can be there. Puffiness of face, periorbital edema, cool and pale, dry and rough skin, hair is dry and coarse, eyebrows are thinned, okay, usually on the lateral uh, 1/3, okay, and discoloration, which is called carotenemia. Hematology, anemia, 10% pernicious due to uh, presence of antiparietal cell antibodies with Hashimoto. Hashimoto is an autoimmune condition, so there can be antiparietal cell antibodies also, which can lead to pernicious anemia in 10% cases. Now, what are the three autoimmune thyroid diseases? So we have Graves, which we discussed, which is presenting with hyperthyroidism. Usually in Graves, we have TSH receptor antibody of stimulating type. That is why we are having more thyroxine hormone. Now, TSH receptor antibody can also be of the blocking type, which leads to atrophic thyroiditis. The cell, otherwise, there can be the thyroid peroxidase antibody, like in case of Hashimoto thyroiditis, which is causing hypothyroidism. So Graves is causing stimulatory antibodies, TSH receptor stimulatory antibodies, and there is increase in T4, T3, decrease in TSH, and there is weight loss, features of hyperthyroidism. Hashimoto hypothyroidism have thyroperoxidase antibodies. There is thyrocyte damage and there is apoptosis, so there is decrease in T4 and T3 and increase in TSH, and there is weight gain. Okay, and there is the other thing is there is thyrocyte damage and apoptosis, which can also lead to atrophic thyroiditis. Now we'll talk a little bit on decurvin thyroiditis and other or thyroiditis or silent autoimmune thyroiditis. So decurvin thyroiditis is usually caused by viral infection or post-viral inflammatory process strongly associated with HLA-D35. So thyroid inflammation damages thyroid follicle, resulting in release of large amounts of T4 and T3 until the stores are exhausted. So that is there is a state of hypothyroidism often persists until thyroid can generate sufficient thyroid hormones back again. So clinical features include painful swelling of the thyroid. It may radiate to jaw and ear. So this is painful. Okay, decurvin thyroiditis or granulomatous thyroiditis is painful. It's post-viral. There is transient vocal cord paralysis, fatigue, malaise, and fever, often preceded by upper respiratory tract infection. Okay, it lasts for a few months. Signs of hyperthyroidism during the hyperthyroid phase. And lab investigation can show elevated T4, T3, near absent radioactive iodine uptake. ESR and CRP are often elevated. Okay. Treatment is NSAID or prednisolone for pain and beta adrenergic blockage because it can reverse most of the hypermetabolic and cardiac symptoms. If symptomatically hypothyroid, they may need short-term thyroxine. Post that, the body can regain the thyroid synthesis. Complete spontaneous recovery to normal thyroid function, 90% of patients. 10% may become hypothyroid and require permanent thyroxine replacement. Now, painless thyroiditis is a variant of Hashimoto associated with DR3. Hashimoto is associated with both DR3 and DR4. Postpartum subtype occurs following pregnancy, also caused by inflammatory damage leading to unregulated release of T4 into circulation. So there is thyroid enlargement without discomfort, there is no pain. 5 to 20% have sequence of hypothyroidism, then recovery. Signs of hyperthyroidism during the hyperthyroid phase can be there if it affects women more than men, also in the postpartum subtype, postpartum period in the postpartum subtype. Again, elevated T4, T3 with near absent radioactive iodine uptake. Beta adrenergic blockage is reversing hypermetabolic state. If hypothyroid, we are giving thyroxine. So difference is this is painless, the other one is painful, and so usually post-viral. Okay. 20 to 30% may become hypothyroid, require permanent replacement, at risk of recurrent episodes of thyroiditis also. I'll come to the FNAC classification for thyroid. So 1 means non-diagnostic. Okay, then you can repeat FNAC with ultrasound guidance. 2 means benign. So you can follow up, clinical and sonographic follow up. Then there is the follicular thing with other undetermined significance. Okay, then you can repeat an FNAC molecular testing or a lobectomy because you cannot differentiate follicular adenoma from a follicular carcinoma along with FNAC. You have to have a biopsy because the basement membrane invasion is one thing that is differentiating follicular adenoma from carcinoma. So you may have to go for a lobectomy and then a biopsy. 4 means follicular molecular testing and lobectomy can be there. 5 is suspicious for malignancy. So you do a near total thyroidectomy, usually near total thyroidectomy or lobectomy. Malignant total thyroidectomy or lobectomy. Now coming to thyroid cancers, we have different thyroid cancers which are papillary. Okay, we have follicular, we have medullary, we have anaplastic, and we have lymphoma also. So papillary is the most common, 70 to 80%. Follicular is the next most common, which is 10 to 15%. Papillary go through lymphatic spread, so it can actually, initial presentation may be a lateral neck swelling, which is a papillary spread into the lymph node. Follicular is heterogeneous spread, so they can go for distant metastasis. Papillary is usually having lymph node positive tumors. Papillary has a good prognosis. Follicular cannot be diagnosed by FNAC, I told, because follicular carcinoma from adenoma has to be differentiated by basement membrane invasion, which can be seen only in biopsy. In papillary thyroid carcinoma, there is a tightly packed cell, clear nuclei with the open chromatin. It's called often ani-eyed nuclei, and there are psammoma body. For follicular carcinoma, for follow-up, you are doing a thyroglobulin. It is used to monitor residual thyroid tissue post-thyroidectomy, and it's a tumor marker for thyroid cancer recurrence. Detectable or elevated levels may suggest persistent, recurrent, or metastatic disease. For papillary and follicular, you can follow up with thyroglobulin. Dystrophic calcification, that is what is psammoma body. Okay, so psammoma bodies can be seen in, like mentioned, papillary thyroid carcinoma. It can be seen in serous carcinoma of endometrium or ovary. It can be seen in meningioma as well as mesothelioma. Now coming to medullary thyroid carcinoma, it is a tumor from the parafollicular cells which is secreting calcitonin. It can be associated with RET mutation and also with MEN2 syndrome, MEN2 A as well as B. Okay, so in a patient with MEN2 syndrome, you look for medullary thyroid carcinoma, or if it is medullary thyroid carcinoma, you have to also look for other uh, things that are seen in MEN2, like pheochromocytoma. Okay, uh, then there is deposition of the collection of amyloid. Anaplastic, there can be giant cells or spindle cells. It has a very poor prognosis. It is growing very fast and is coming as a huge size. Lymphoma, usually non-Hodgkin's. Uh, there can be history of Hashimoto also. Hashimoto thyroiditis can predispose to lymphoma. Okay. Usually, the treatment is chemotherapy with CHOP regimen. So next one question. A 40-year-old woman comes to physician with 3-month history of lump on her neck. The lump is mildly painful. She appears healthy. There's swelling on left side of her neck that moves on swallowing. So mostly thyroid swelling. Cardiopulmonary examination shows no abnormalities. TSH is 3.6. Ultrasound shows 0.4 centimeters. So very small hypoechoic mass in the left thyroid lobe. FNAC shows neoplastic follicular cells. Molecular analysis show mutation in RAS gene. So what is the appropriate next step in management? So a thyroid nodule with neoplastic follicular cells, mutation in RAS gene, they all point towards follicular thyroid carcinoma. So what do? You do a thyroid lobectomy, hemithyroidectomy. It is preferred in patients for treatment for patients with well differentiated intrathyroidal cancers, which is less than 1 centimeter without nodal or distant mets or high risk features. High risk features means patient age more than 45, family history of cancer, history of head and neck irradiation. So in these patients, you can go for hemithyroidectomy, allows for definitive diagnosis via the histological analysis showing invasion of basement membrane, and also definite management with a high probability of cure. Preservation of the contralateral lobe also decreases need for thyroid hormone replacement post-surgery. Okay, and it also mitigates the risk associated with thyroidectomy, which is hypoparathyroidism. So you don't have to replace calcium, you don't have to replace thyroxine. You can go for hemithyroidectomy in a well differentiated less than 1 centimeter lesion without nodal or distant metastasis. In patients with intrathyroidal more than 4 centimeter, extrathyroidal spread metastasis, high risk features, hemithyroidectomy is contraindicated, and you have to go for total thyroidectomy with post surgical radiation maybe. These are the complications of thyroidectomy. Usually hemorrhage is one of the complications, and if there is a swelling in the region post surgery, you have to immediately open, because the hemorrhage, the blood can accumulate and can cause respiratory distress. There can be respiratory issues. There can be thyrotoxicosis post surgery, usually in the intra-op period in a hyperthyroid patient if there is not they've not been optimized for surgery, and it can also lead to thyroid storm. Then recurrent laryngeal nerve paralysis, which can lead to hoarseness of voice, or external laryngeal nerve, which can uh, lead to problems with the pitch of the sound. Hypoparathyroidism and hypocalcemia due to removal of parathyroid gland. Then hypothyroidism, wherein you have to replace thyroid hormone. There's something called hungry bone syndrome, which is a phenomenon related to high bone turnover associated with hyperthyroidism after total thyroidectomy. Hyperthyroid patients can experience severe or prolonged hypocalcemia despite normal levels of parathyroid hormone. So other serum electrolytes in hungry bone syndrome are low phosphate, low magnesium, and high potassium. So it is due to high bone turnover. So there is low phosphate, low magnesium, and high potassium. Okay, now I just wanted to talk about Wolff-Chaikoff effect and Jod-Basedow effect. So, in short, Wolff-Chaikoff means excess iodine leading to decrease in thyroid hormone effect, the hormone synthesis, and leading to decrease in thyroid hormone. Jod-Basedow means excess iodine is leading to excess iodide organification, and excess thyroid hormone. So that is George Basedow. Okay, so George Basedow is seen with abnormal thyroid gland free from the pituitary control, like Graves, toxic multinodular goiter. Okay, so they are free from the pituitary control. They are producing more and more thyroid hormone. So it is leading to hyperthyroidism. So that is a iodine-induced hyperthyroidism, like an endemic goiter, Graves, or toxic multinodular goiter. It can be like amiodarone diet or contrast, which leads to excess iodine. Now, Wolff-Chaikoff is seen with thyroid gland under pituitary control, like in Graves, where there is a hyperthyroid state or normal thyroid euthyroid state, and there is increase in iodine, which is leading to hypothyroidism. Okay, in autoimmune diseases, it persists like that. Normal thyroid escapes this iodine-induced hypothyroidism after 10 days. That is Wolff-Chaikoff and George-Basedow. Now a word on postpartum thyroiditis. It is occurrence of thyrotoxicosis, hypothyroidism, or thyrotoxicosis, followed by hypothyroidism. Okay, so that can be thyrotoxicosis alone, hypothyroidism alone, or thyrotoxicosis followed by hypothyroidism in the first year postpartum. In women who were clinically evident, no clinical evident disease before pregnancy. Okay, so in the postpartum period, in the first 1 year, if you are having either thyroid hormone excess or hypothyroidism or thyrotoxicosis followed by hypothyroidism, it's called postpartum thyroiditis. It's an inflammatory autoimmune condition, almost exclusively in women who are thyroid antibody positive. So the difference between Graves and postpartum thyroiditis is thyroid antibody may be positive in both Graves and postpartum thyroiditis, but thyroid receptor antibody, which is a stimulating antibody, is present only in case of Graves. And all patients with postpartum depression should also be screened for thyroid dysfunction. TFT should be done in a woman also having poor lactation. So postpartum thyroiditis, usually in the first 3 months, it's occult, no treatment or needed. TPO antibody may be positive. Graves is usually after 6 months. It's overt and treatment according to the guidelines, and uh, thyroid receptor antibody is positive. Okay, increase in iodine uptake also. Now coming to hyperparathyroidism. So parathyroid glands are 4 in number, which is superior and inferior parathyroid glands, which is behind the thyroid gland. Okay. So usual symptoms of parathyroid, we tell it like stons, bonds, crons, and psychic mons, which means stons means there can be hypercalcemia. Okay, there can be stone, so there can be pain also, there can be cron. Okay, there can be psychic mons means there can be psychiatric symptoms like disorientation, delirium. In hypercalcemia also you come across confusion, paranoia, hallucination, forgetfulness, and all, alteration, hunger, and sexuality. There can be fragile bones, osteoporosis, kidney stones, okay, excessive urination, abdominal pain, tiring easily, bone or joint pain also. Okay, it can be due to parathyroid adenoma or hyperplasia. Okay, at bond there can lead to resorption. So the calcium and phosphorus are released to blood. In kidneys there can be increased calcium reabsorption and increased phosphate excretion. And it can activate vitamin D, and in the intestine the vitamin D leads to increased calcium uptake. So thereby there is increase in calcium and decrease in phosphate. So lab comparison between primary, secondary, and tertiary. Primary means the problem is within the parathyroid itself. Okay, that means there is a increase in PTH, or it can be sometimes normal, and this increase in PTH is leading to increase in calcium. So first problem is increase in PTH, leading to increase in calcium. increase in calcium and decrease in phosphate. That is what parathormone do. And increase in vitamin D also, because it leads to activation of vitamin D. Secondary means there is suppose there is initially like in CKD, there is initially low vitamin D synthesis due to CKD. This low vitamin D leads to low calcium. Low calcium stimulates parathormone production. So there is increase in parathormone. In CKD, phosphate excretion can be impaired. So there can be either increase in phosphate, or due to increase in PTH, there can be decrease in phosphate. In tertiary hyperparathyroidism, that means the parathyroid has become autonomous and it is producing higher amount of calcium, and parathormone is very, very high. Okay, so calcium is high, phosphate is usually high. Okay, it can be in a long-standing secondary hyperparathyroidism, and vitamin D can be low. So primary hyperparathyroidism, secondary and tertiary, we told PTH is high in all of that. Calcium is high in primary, low in secondary. Tertiary also it's high. Phosphate is usually low in primary. Vitamin D is very much reduced in secondary. Primary, 85% is solitary parathyroid adenoma is present. Important differential is FHH. Familial hypocalciuric hypercalcemia. Okay. Then secondary causes include chronic renal failure and vitamin D deficiency. Tertiary is caused by end-stage renal failure due to long-standing secondary hyperparathyroidism. So this is primary, secondary, and tertiary hyperparathyroidism. You have to know these lab values. They can give and ask which type of hyperparathyroidism is that. Now, a word on emergency access to trachea. So it can be cricothyroidotomy or tracheostomy. Cricothyroidotomy is a more emergency procedure. It's easy stab through cricothyroid membrane. Okay, so this is the thyroid cartilage, this is the cricoid cartilage. There is a membrane in between that, and you're giving a vertical incision on the cricothyroid membrane. Insert any small round airway such as Biroc casing. Anesthetic is not essential because it is in a patient who has already collapsed, and you can't do an oropharyngeal airway if you are not able to put in the tube through the mouth. You do a cricothyroidotomy. Formal tracheostomy is a formal planned procedure. Okay, you can do a surgical tracheostomy or a bedside, using the aseptic precautions. And here the incision is horizontal. Okay, it's not usually an emergency. Needful anesthetic, ideal for temporary or permanent intubation. Hold in the second or third tracheal ring. We mentioned that tracheal rings. There are many tracheal rings. Up to fifth or sixth, we are having thyroid gland. Okay, so you remove the isthmus. You just elevate the isthmus or remove the lift the isthmus, and then you put a hole. Usually after dividing the thyroid isthmus. Inferior thyroid veins can be troublesome. So you have to do an ultrasound. You have to make sure there are no vessels in the tract, and then you plan the procedure into that is tracheostomy and cricothyroidotomy. So that's all. Thank you so much. We'll see you in the next video.